Hi, everyone. I'm Nicole, a continuing education coordinator for the Collaborative for Accountability Improvement, and we would like to welcome you to our first webinar of 2022, Medical Malpractice, Clinician Perspectives for Litigators. I'd like to start with a few housekeeping items. Please keep yourself muted. You can submit questions to the chat at any time. We'll address questions at the end during the Q&A portion. Consider setting your view to speaker view. That way you'll have our speakers in full screen while they're sharing their experiences with you today. I want to now introduce today's moderator, Caitlin Harrington. Caitlin is both a physician and attorney in Seattle, Washington, where she spends a portion of her professional life as a practicing internal medicine doctor and a portion working on communication and resolution program-focused projects with Sweet Law Firm and with us at the Collaborative for Accountability Improvement. Thank you so much for being here with us today, Caitlin. And with that, I will hand it off to you for today's session.
Thank you, Nicole. It's a pleasure. Good morning, everyone, and thank you for joining us. Welcome to the first in a four-part webinar series focused on exploring the perspectives of those involved in medical malpractice litigation. The series is brought to you by the Collaborative for Accountability and Improvement's Attorney Alliance, and over the next 4 months, we'll include conversations with clinicians, attorneys, patients, and families. In this initial webinar, I'm excited to welcome our panel of physicians, Dr. Jason Lees, Dr. Lydia Nightingale, Dr. Joe Shapiro, who will share their experiences of the malpractice process. In the next hour, they will provide insights on the emotional impact on clinicians after harm events, and as well as litigation, discuss strategies that litigators can use to support clinicians through the process of litigation, and explore how peer support systems can be optimized to reduce clinician distress and potential burnout. I would like to make special note that with this webinar, we will be sharing the personal experiences of clinicians with you so that attorneys might be able to better understand the vulnerability of clinicians involved in malpractice process, as well as the most productive ways to interact with them and to support them. We are doing this in service of taking care of patients. And I know that all the panelists with me today feel very strongly that the challenges faced by clinicians are not in any way comparable with the suffering of patients and families who have experienced medical harm. I'm now honored to introduce our 3 panelists. Dr. Joe Shapiro is an associate professor of otolaryngology and head and neck surgery at Harvard Medical School. She is also principal faculty for the Center for Medical Simulation in Boston and a consultant for the Massachusetts General Hospital and Department of Anesthesia, Pain, and Critical Care. In 2008, she founded the Brigham and Women's Hospital Center for Professionalism and Peer Support, where she has served as director for over 10 years. During that time, the center became a model for national and international institutions seeking methods to enhance a culture of trust and respect, and to improve clinician well-being and patient care. For many years, she has been involved with the Collaborative for Accountability, serving a term as chair of the Senior Advisory Group, and now as a member of the Best Practices Committee. Welcome, Dr. Shapiro. Dr. Lydia Nightingale is a Chief Medical Officer at Variety Care in Oklahoma City. Variety Care is a community health center that operates multiple sites across central and southwest Oklahoma, focusing on meeting the needs of those who might not otherwise have access to healthcare. Prior to moving into that role, she was director of women's health at Variety Care. Dr. Nightingale began her career in academics as an OBGYN at the University of Oklahoma, where she was an associate professor and fostered her love of education. While there, she worked with colleagues, including Dr. Lees, to develop a colleague support panel. In 2018, she was recognized by the Journal Record as one of the 50 Making a Difference Oklahoma Women of the Year. Dr. Nightingale, thank you for joining us. Dr. Jason Lees is a professor in the Department of Surgery at the University of Oklahoma. His clinical focus is in acute care surgery at the Oklahoma University Medical Center, the only level 1 trauma center in Oklahoma. In addition to being the surgery residency director since 2011, he has served as vice chair of academic affairs with the department since 2018. Within Oklahoma University Physicians, he co-chairs the Practice Groups Committee on Wellness and Collegiality. Since 2013, he has co-directed Oklahoma University's Health Colleague Support and Professional Development efforts. Currently, he is helping in efforts to identify struggling faculty and provide them with resources and guidance to adapt and succeed. Dr. Lees, a very warm welcome. I would like to turn to the initial portion of this webinar. Dr. Shapiro, to start us off, would you be able to share your experiences with medical malpractice, as well as your thoughts on how litigators can best support clinicians through the process of litigation?
I'd be glad to, and it's truly an honor to be here. And I want to thank all of you for showing up and caring about this as much as we do. And obviously the collaborative has just been such an amazing force, I think, in doing the right things by patients and families. So I'm so grateful for that work. Thank you. I'm going to tell a brief story and then hand it over to my other two colleagues who are going to tell theirs in a bit more depth. And then I'm going to talk somewhat about peer support generally afterwards. So I've had two experiences with the legal system as well, all told my whole life. The first one was a patient who filed a claim against me and 15 other otolaryngologists in Boston within my first year of practice. And he alleged that we had all failed to detect a listening device that was placed in his larynx by the FBI when he was sleeping. Believe it or not, that actually got through the tribunal and went on, finally fizzled out because he wanted to represent himself and then just never really showed up for anything. But my second and more meaningful encounter was I had operated on a lovely older gentleman for Zenker's diverticulum. This was my wheelhouse. It's what I was known for, and spent really most of my training and practice in perfecting as much as possible. So I approached the case with an endoscopic approach, and I tell you this because it's just a little more challenging than the external approach, but it's also ultimately better for patients. And in one of the known risks for the procedure is a perforation of the pharynx with the laser. It's usually, if it happens, it's very small and it heals on its own. And unfortunately, it happened to this gentleman. It hadn't happened to any of my patients prior. And he ended up getting very, very ill. Ultimately, he recovered. But the family, several years later, many years later, brought a lawsuit against me for negligence. And so I went through a full trial, which ended up in our favor, and meaning that they didn't find fault for me. And it was pretty horrendous, the experience, which I think that anybody who's been through it can relate to. My reaction to, I think when we think about this together today and going forward, you have sort of two things that you're handling. One is actually what happened to the patient, which usually was several years before the claim is filed. And then also what's now happening with regard to being involved in litigation. And they're separate but very related kinds of emotions. And what I want to say that, the first most traumatic thing that's ever happened to me in my career was actually causing this complication for the patient, even though he did recover. And that was the most traumatic thing. And the second most traumatic was going through litigation. And they're, as I say, related in many ways. I told you about the first case because it was true. This really actually did happen to me and my colleagues. And it was emblematic, and it is emblematic of, I think, why the collaborative is in place. And we're trying to really help many organizations use this process. That the litigation system really doesn't serve anybody well. And so we're, of course, going to talk today about how it affected us, with the full knowledge that there'll be obviously a separate webinar on how it affects patients and families, but with the full knowledge that we're not comparing sorrow or trauma in any way, shape, or form. It's just ours doesn't compare to what patients and families go through. It just can't and shouldn't and doesn't. That said, it is a very, very specific, awful, traumatic experience to be named in litigation. It's extremely public, and it is, and yet it's hidden from our colleagues in a sense that we don't get to share with each other what it feels like generally. As you all know, the way the system is set up is if there is an adverse event, the first thing you're told is don't talk to anybody about it. And certainly litigation, that's the first thing you're told is don't discuss this with anybody. So for all you know, you're the only person who's ever caused any harm to a patient. And for all you know, you're the only person who's ever been sued, despite the fact that, technically we understand that's not true. That is pretty much how you feel. And I really want to turn it over in terms of the next portion of the program to my colleagues. But I do want to say to the litigators that we are so vulnerable in your hands. And I think of it the way patients are vulnerable in my hands as a surgeon. We're asked now to, the way I look at it is we're almost like given a part in a play that we didn't really audition for, and we have to learn lines and learn a language and be directed by people that we don't know, and really hope that those directors, have our best interests in mind and know what they're doing. And for a lot of us in medicine, we're not used to being in that kind of vulnerable position, which is interestingly, of course, quite parallel to what we all experience as patients. But I think that we don't necessarily see that we're so vulnerable, and we may not show that to you as litigators. And I was really conscious of this, and I had a wonderful relationship to the lawyer, George Wakeman, in my case. And I said to him in jest, but not really, I said, okay, every time we meet, George, I want you to start off every meeting with saying, Joe, you're really, really a great surgeon. Obviously, he had no position to be able to reassure me of this, but I was trying to tell him, as I did explicitly, this is really so hard, because what is being said about you is you're a bad doctor and you're a bad person. You have failed, you've been negligent, you've done something terrible and harmful and unforgivable is the way it feels to be, named in a claim. And so I think I wouldn't want you to underestimate just how horrible we feel. No, I do think those of us who are in the position of being defendants are very much, may handle this in different ways. And I think maybe some people might get more defensive or more angry, but it comes from the same place, which is people feeling really ashamed about what's happened and what's happening. And so I think, having that understanding of, as a litigator, that we are very vulnerable and need support. And we, of course, are going to argue that, or hopefully convince you all that one of the most important supports you can give us is getting us some peer support. But in addition to that, having your support for us as people, and not just as professionals, what this does to our sense of self and our sense of competence and our sense of trust in our relationship with patients. It's really quite devastating. So I'm way on the other side of this, but it still was, as I say, one of the most negatively impactful things that I've experienced. And I really did want to share that because I think the more you understand about how it feels, the better you can help us be present and participate in a way that's as constructive as possible. So with that, I want to turn it over. As I said, we'll come back to the whole idea of peer support and also some of the data on what we know happens to clinicians after adverse events and errors in particular. So thank you. And Lydia, can I turn it over to you?
Absolutely. Thank you very much. And I really echo exactly what you're saying. So I'm going to share a little of my experience, and it very closely aligns with everything that was just shared. And I had the benefit of having Jason, Dr. Lees, with me. I thought it was interesting when Dr. Shapiro, when Joe just said that, she had that experience very early on. And I think that's something also to keep in mind is when these events happen very early in your career, I think that also impacts you. My event was 2 years outside of my residency, so I was still a fairly new doctor, and I think you're still learning your way and you're still practicing. So I had a patient that I had taken care of for her OB, delivered her twins. We'd had a great rapport, and she came in at 6 to 8 weeks for an interval tubal ligation that was uncomplicated with no problems at all, but came back in 3 days later and ultimately presented with group A strep sepsis. At the time, there really was nothing in the literature. It really kind of became a sentinel event because that has now become very common and understood, but at the time it was not known. And so I had the fortune of having Dr. Lees, who was the trauma surgeon on, that really helped and walked me through that. But this patient was deathly ill with a disease that we now understand carries about a 75% mortality rate. But at the time, we didn't really know what was wrong with her. We took her to the OR. She had multiple abdominal washouts. She had a hysterectomy long-term. She was in the ICU for 6 weeks. She had infarcts of her extremities, all 4 of them, which ultimately ended in amputations. She suffered a stroke. It's just really a litany of events that, again, as a fairly new physician, 2 years out of residency, you question what's going on. Also, it becomes, multiple surgical teams involved. But having a trauma surgeon walk through, there's been so many things, and then it was a 5-year process. But the very first night that she came in, it's very solidified in my mind. Jason looked at me, and I didn't know him well at the time. We've become very dear friends over the years, and he's my go-to when I have questions. But he looked at me the night that she came in, and he said, I don't care what happens, and I don't care how great of a job and how good you take care of her, you will be sued. And it sounds really harsh, and it to others may sound really, and even at the time, I remember thinking, I don't know this guy, and he doesn't know how well I'm going to take care of her. But as that went on and I took care of her, and 2 years later when I got my lawsuit, and they actually in the deposition did claim that I was a good doctor and, I did provide good care, I was able to go back, and that comment to me was so helpful, because knowing that he could say that to me before he saw any of the care that I did and understand the process. And he actually did go on to say they will have medical bills. This will have, outcomes that will be outside of your control. You just need to know that. And it really helped me. And again, as to what Joe was saying, these areas where you're so vulnerable and you lay awake at night, and we go into medicine because we want to help people, and when it doesn't go that way, we always question, what could we have done differently? What should have been done? Is there something that could have changed? Where was the turn that went wrong? And even when they're not there, and Jason and I talked about this, he said there will be times when you will potentially do something wrong, and then you have to figure out how you deal with that. But having those conversations with somebody that was in the middle of it was so helpful. But then again, when you get that lawsuit and they say, and don't talk to anybody. It's really very isolating. You're always questioning, you know, what can I say? Who can I talk to? I had an excellent attorney as well who did such a great job of preparing me and talking me through it. Another thing that he said that was so helpful to me was, this is going to take forever, which again, when you don't know and you can't really talk to people and it does feel very shameful, telling me that was so great. He said, you may go months and not hear from me, and that's okay. You need to know, if you need to pick up the phone and call and check in, that's wonderful, but know that things are happening and it's okay. And then you may hear, and we may have several weeks in a row where you hear from us a lot, but it was a 5-year process over, you know, from the time of the case till things were eventually settled. But it became, a long drawn out process of, again, you get through the event, you're able to kind of cope with it, and then 2 years later you essentially relive the whole process again of, what can I do? And everyone telling you that you're a terrible person and you're a terrible doctor and you've made all these terrible choices. And so I think that support is so important. I think the one thing, again, after, the benefit of going through litigation, I can talk about it now a lot, and I'm very open about that. Again, OBGYN, it's a high litigated field. In my residency class of 6, we all had lawsuits before we were out 5 years, all 6 of us. So it's, again, things that I think people don't realize. They're not, it's just that heavy burden. And so finding that peer support and people that you can talk to. When I know of somebody now as the chief medical officer, I've had a couple of my own providers who've been served lawsuits that have ultimately been dropped. But when I've had to tell them that, and then the first thing that I share with them is that I have been sued, you can actually watch their shoulders relax, in that they know that they're not alone, because it is this just terrifying fear and shame that people have of not knowing, one, what to do or who to talk to. And so I think there's just such a stigma about it. And again, I think it goes back to, we've gone into this because we want to help people, and nobody, with some exceptions, I'm sure if you've listened to the Dr. Death podcast, there's some exceptions out there. But as a whole, physicians have gone into this because we really want to help people. When these bad outcomes happen, you already are struggling. And then again, to have this pile on top of you creates this whole other burden and anxiety that we already are struggling with. And so again, I kind of go back to that support of Jason, of telling me that from the beginning. So from my personality and for me, it really did help me as I moved through that. So, I think, the other thing that I just to point out for mine, because it was such a traumatic experience, I felt like I was having everyone look at me. I had multiple services involved. And then, I got on an elevator again as a, big academic center, and got on with an orthopedic surgeon that I knew because I had trained there. And then he said, "Hey, you're that person that has that girl in the ICU." It's like, I am, and so you have this feeling that people are already talking about you, and then, to have that confirmed. So there's just this kind of natural tendency where you're always kind of looking in. And so having that peer support, I called Jason regularly. And so again, I think this is why it's so important, is just to see that emotional support is needed, because physicians are not good at it. And they tend to really go internal. And if you don't have that person that can kind of pull you along, it really is very, very isolating. So I'll turn it over to Jason, and he can tell you his side of the story of wanting to block my number, probably.
Never. Well, first of all, I want to thank everyone for inviting me, and Dr. Shapiro and Dr. Nightingale, thanks for that introduction. This was something that really, was a defining point in my career, even though I probably didn't have the same stress level that Lydia did, but we realized along the way how impactful these events are. And again, I think to echo what Joe said, is this isn't the same as what patients go through with their loss, or the families. But when we started making the case and realizing how isolated we felt, I've been involved for disclosure 2 lawsuits where I've been named. And the most important thing that I remember hearing in them was the attorney telling me, this is not like medicine. Like in medicine, you go and you either, you see a lot of patients during the day, you see clinic, you're placing orders or you're doing procedures, but the start and stop nature of a lawsuit where there's a flurry of paperwork, and you wonder what happens, and then something else happens, and it's just so drawn out. It's so different than what we experience in medicine. And hearing that that is how it was going to be, and it was going to take several years perhaps, was very reassuring. I also think and I think we've all realized it to some degrees during the COVID epidemic, that being isolated is not how we are well adapted as humans, and being out there on our own, having interaction of friends, peers, etc., is incredibly important, I think, to our well-being. And these events really truly make you feel like you're on an island, and I don't think anyone goes into this feeling like going into medicine to hurt people. I agree with the Dr. Death, and I'm sure there's others out there like that probably need to find other careers. But when you look at the data in the surgery world, where 75% of trainees in one study have imposter syndromes, I mean, we are very vulnerable as physicians, and this just reinforces that vulnerability at times, especially at critical points in our career, whether as trainees or junior attendings. And I think the other part of it that really stuck out as we started to build a case for it is, and again, to use the COVID epidemic, it's not when you lose people out of the healthcare system, even it's a nurse or a physician. I mean, after college, it's about 7+ years before you get a practicing physician to refill that pipeline. And if we're losing people out of the pipeline to care for patients, that doesn't help anything either. And as many have pointed out, like a lot of times it may not be truly the physician's actions, but it's, we're being called to be perfect in an imperfect system, and we're part of that process. But we recognize that a lot has gone on to train us. We try to recognize that and made the case in our institution and to our leadership that, once you hire a physician, it's a, several $100,000 potentially investment. And if they are not able to continue in that world, it doesn't help the institution, it doesn't help society, and really trying to build the case that, that we need each other. The analogy I also use in trauma is, I see a lot of traumatic injuries, a lot of them head injuries, spinal cords. And while I can share expectations, I've never been in that situation. And that's why, there's institutions like patient support groups, whether for cancer or for traumatic injuries. But when we've been able to get patients or families matched with who have been through it, matched with other families, they're able to connect a lot better and provide a lot better perspective. And I think the same thing happens on when you're the defendant. You may not, I think attorneys do a great job, like I said, of explaining what's going to happen, but it doesn't feel like it's their reputation, their, assets, all those things at risk. And really hearing it from people who have been through it, I think carries a lot more weight. So it requires, I think, all of us in recognizing this isn't just purely about defense, but it's also about making the system better. And I teach a class on the business of medicine each year to 4th-year medical students, and every one of the topics is always medical malpractice and how could you have a better system. And I know it's a really challenging process to try and recognize all of the stakeholders in a fair and equitable way. And the tort system has evolved as it has, but it's not perfect, I think, for any participant, having seen many sides of it. So that's my perspective on it. And I'm really honored to be able to be part of this panel And thank you all.
Thank you, Dr. Lees. Thank you. That is the perfect segue to turn to the second portion of this webinar, where we talk about peer support and the ways it can be optimized to reduce clinician distress and potential burnout. So I'm going to turn to Dr. Shapiro to provide us with an overview of peer support. As I was saying earlier, Dr. Shapiro founded and directed the Center for Professionalism and Peer Support at Brigham and Women's Hospital. Thank you, Dr. Shapiro.
Again, thank you for having me, and just special thanks to Lydia and Jason for sharing. This is my disclosure, and I wanted to start with this quote from Parker Palmer, who's an activist and educator, and he talks about institutions being where the human heart either gets welcomed or thwarted or broken. And I think those of us who are involved in trying to improve organizations really do it because we want to help people in the organization be able to do the work they're meant to do, that they want to do, and have that work be wonderful and beautiful. In our case, giving patients the highest quality and safest patient care, and being able to have a career that's sustainable. And so I think many of these things are going to rest upon organizational responses to some acute and chronic stressors. In particular, obviously, we're focusing today on the stress of first of all, I'm just going to talk about the stress of making a medical error. We care about this because our response after harm events is very much related to what we've got to give. In other words, you can't give what you don't have. And if you are falling apart emotionally, the chance of your being able to be very present and compassionate for patients and families goes way, way down. Same thing with providing safe care, for being able to continue and trustworthy relationships, and of course, to sustain, your own well-being. So that's why we care about doing this. I'm just going to go through some of what's known. This is just my way of putting it together, but what's known about the emotional impact of errors on clinicians. First of all, obvious sadness, because, we just hate seeing anybody suffer. And I think most of us then go on to this feeling of shame. And shame is where you go from saying, I feel really terrible about this, to I feel really terrible about this, and it happened because I'm not good enough. I'm a bad physician, an inadequate pharmacist, a bad nurse. And it can trigger, as Jason was mentioning, this in the imposter syndrome. I haven't ever been good enough to do this work, and this just proves that that's true. And this deep shame, which is a very difficult emotion to bear. I think I was always wondering, why are we so ashamed? And there was a wonderful exploration by Helmreich that he looked at the similarities between medicine and aviation and found that both stress the need for perfection and a deep perception of personal invulnerability. So what we believe is that the way to keep patients free from harm is to expect perfect performance from ourselves and each other always, which would be great, but literally impossible. You cannot eliminate human error from any enterprise. We still have an obligation to prevent harm, but it will never be by zero errors, because we are human, and humans make errors at very predictable rates, as a matter of fact. So our job as in organizations is to decrease the chance of errors. It will never be zero, but also set the system, look at the system and see what's putting us more at risk for making errors, and then setting up a system where the natural errors that might happen don't reach the patient. But that's very different from what we have internalized, which is, I'm never supposed to be anything but perfect. And that's very difficult to bear when you feel you're supposed to be perfect and you realize, of course, I'm not here. I've caused harm to somebody. I think there's, a lot to be afraid of. We're afraid of what's going to happen to that patient. Will the family patient lose their trust in me? Will my colleagues judge me and lose their faith in me? And there's evidence that does happen, that we tend to judge each other without even knowing why or how something happened. And then we're afraid, we're obviously afraid of, people are afraid of job consequences, getting fired, being put on some kind of probation, or getting sued. It's a huge fear. It's ever present, and all of these fears are quite realistic. And I think a lot of us are angry, can feel some anger anyway at the system, because, well, I would ask you rhetorically, any of you works in any healthcare organization, did your healthcare hospital, your organization, send out a memo saying we're done with shame and blame? No, no one sent out that memo, but shame and blame is how we approached harm events forever. And litigation is the ultimate shame and blame. It's not, oh, and by the way, the reason shame and blame is terrible is that it actually doesn't lead to a safer system. It puts patients in the future more at risk. Never mind what it does to the clinicians who are experiencing shame and blame. It's a terrible culture, and that's why we've said we're switching to a safety culture. But you can't just switch from something that you've been doing in your profession forever and tell somebody, oh, it's a new day. And so we have to look at the processes like litigation and see them sometimes for what they are, which is litigation is not about being a learning organization or improving care going forward. It's about finding who is at the sharp end of the error and punishing them. And so it goes completely against, shame and blame goes against actual patient safety. And I think when we realize, gosh, these processes, and I just put some of them up here, they're supposed to be done in a safety culture fashion where there's trust. There's the ideas. It's not that we're not accountable, as I put in the slide before, just to remind everybody, it's not for us to say, oh, it's not my fault, it's the system. It's to say, what am I accountable for? The choice that I made in error. I thought this was the right thing to do, but apparently it wasn't when I saw the outcome. So how can I either get better at doing it or have more supervision or whatever it takes? And the system needs to look at how they may have set the individual up to make the error, because even though I won't make the same mistake again, someone else will. And so if you look at all these processes I put here, and some are for other countries, like Netherlands has the inspectorate and such, many of them can be done in a safety culture fashion, where the idea is, let's learn from this, right, and support patients and families, versus we're just out there to get revenge, which may feel good in some ways, but it doesn't actually. It makes the system less safe. And all of these things, and I had said in the beginning, and both Lydia and Jason absolutely illustrated and underlined, is you start to feel very isolated, and especially given that we're told don't talk to anybody. And isolation, because we're humans, and humans are very social, causes acute and chronic stress. So you've sort of then been put in this kind of toxic stew that really does not do much good for oneself and ultimately for the patients and families. And so we have tons of data on things that, the experience that people have. And I'll just show you. So, here, sorry, let me backtrack. Litigation, as I said, there's some parallels, but I think the shame and fear and anger and isolation, those are all hand in hand with just actually being involved in litigation for all the reasons that you understand. It has all of these effects on us. So what I want to point out is that I'm not saying, I don't think any of us is saying, oh gosh, we shouldn't feel any of these things. I mean, we're involved in harming a patient inadvertently. That should feel terrible, right? In what universe would we want people to train a generation of clinicians that was like, nah, doesn't bother me, it's the system, not my fault? No, I mean, these are normal reactions. They're normal reactions. It's the events that are abnormal. This comes from the first responders who have very robust peer support programs, is the things that we see and face and have to deal with in our profession are just unique to our profession and very traumatizing. And so, and many times we do move through this. I'm not, none of us is saying everybody, really runs into big trouble. No, but many people do. And so I'll just put up a couple of studies that show that. For one thing, can you imagine that when you've made an error and you're feeling this flood of very negative emotions, that may affect the way you speak to the patient and family? And rhetorically, I would say, how could it not? Of course, it's going to affect that. And so I actually got into this originally because I felt like the way physicians and other healthcare providers were communicating with families after harm events was awful. And I felt like we can't keep telling us do it better without acknowledging, like, well, why are we so terrible at this? And one of the reasons is because we're not managing our own emotions not before, but as we are communicating with patients and families. And it leads people to do really bad things, physicians and other healthcare providers in their communications. So that is one negative effect. This would be on patients and families of not managing our emotions, not supporting us. In addition, we know that burnout and depression are independent predictors of having made a recent major medical error. They're very closely associated. And we know that if you've made a medical error, you have a higher chance of becoming burnt out. And if you're burnt out, regardless of why, you have a higher chance of making a medical error. So we could just keep letting this happen, but we shouldn't. We have to do something about it. And very sadly also, being involved in medical error, at least for a physician, is a risk for increased suicidal ideation and for actual completed suicide. And, that's horrible. Again, we've got to interrupt this cycle, and it is not by losing compassion for patients and families. If anything, it is gaining compassion, but also seeing how our own reactions might interfere with our demonstrating compassion. So we looked at this and, want to study, well, how do we facilitate resilience, which is basically learning and growth through trauma. And how do we facilitate that? This was a physician study in physicians. And by the way, most of what I've said is referable to other healthcare providers who've been involved in harm events as well. But some of the studies were done just with physicians. And this was one question we asked: if you're involved in a medical error, where would you want to get support? And 88% wanted to be supported by a peer, even though we had great mental health professionals, employee assistance program professionals. There's something about talking to somebody who's been there, who gets what it feels like. Another study looked at also resilience in terms of gaining wisdom through trauma, in this case, the trauma of having harmed a patient, and what were the factors that actually helped physicians, this was a physician study, to actually develop resilience, because not everybody does. And some people really, really, really remain very harmed and diminished and don't practice as good medicine as they did before. Or as Jason was saying, they leave. They just say, I can't do this. But the factors that correlated, by the way, with actually facilitating resilience, we're talking about it with colleagues, and also disclosure and apology, which my colleague Beth Kay, who's on this call, has urged me to stop saying and use the term communication, which is a better term, those are actually the right thing to do for the patient and family, obviously, but also they happen to help us heal, which is a side benefit. So basically, peer support, what we're talking about here is formal peer support. It's not instead of informal, where somebody checks on you, hey, how are you doing, right? But that is not always going to be adequate. For some people it will be, but not for everybody. So formal peer support is where there's an outreach and an offer from someone who's trained, a clinician, a frontline clinician, not a behavioral mental health clinician, but somebody, surgeons, internists, intensivists, et cetera, who are trained to be able to sit with virtually a colleague who's been involved in an event, a harm event, and to help them process what's happening and also way forward, what to do going forward, how to move through this, because you can't move around it. And again, for some people that will be enough, but some will need further, more longitudinal help, professional help. And as you may or may not know, there are tremendous cultural and structural barriers to our receiving or being willing to ask for professional help. And that's led to some of the awful statistics like of depression and burnout and suicide. So one of the jobs of a peer supporter is to connect this last one, is to connect the peer with further resources should they want to, by destigmatizing that referral and also facilitating it if they want it. But the most important, I mean, I'm not training to be a peer support, training you to be a peer supporter, but just to give the litigators and colleagues in the who are participating today this idea of what are the fundamentals. The most important thing is giving your loving presence to your colleague. You add on some actual skills help, not by telling them what to do, but using non-judgmental curiosity and problem-solving guidance and helping them reframe what they're going through, again, in service both of the patient and family they're going to be taken care of, and in their resilience, their growth and learning, so that it doesn't destroy them. So I've helped over 100 places develop peer support programs, and I have to tell you I've learned a lot along the way. But the two most important principles as far as operationalizing this is it should be proactive. We can say that we've got a resource here, I'm here, and we did this when I was at the Brigham. We trained a whole bunch of frontline clinicians to be peer supporters, and literally nobody called. I said it was like we were all dressed up for a party and nobody came. My colleague, Tim McDonald, who he and I co-wrote an article in the New England Journal about peer support. We wanted to title it, If You Build It, They Won't Come. But the point is, you can have these wonderful programs, but we are so enculturated not to say, I'm hurting, I messed up, and it hurts. So you've got to do something where I believe you actually offer the peer support in a way that's much more proactive. So that's a reaching out. You also want it to be easy to access if someone self-identifies as needing support, of course. So we should offer peer support. I hope I've argued certainly for errors, clearly, and for anybody who's been named in a claim. I put this up here. This is not a financial relationship, but I am on the advisory board for the Physician Litigation Stress Resource Center. It's actually not just for physicians, but it's an old name that we ended up keeping. There's lots of resources there. I think everybody should, have those put in front of them as a potential resource, but also just like Lydia had spontaneously and thoughtfully from Jason, is a colleague who can tell you, this is certainly, if you're named, he did it proactively, which is really beautiful. But once a colleague is named, is getting an outreach from someone who's been through it and can say, there is a light at the end of the tunnel. Yeah, it's really hard. Tell me what's on your mind. But not from a legal point of view. Obviously, we're not lawyers. We're just people who've been through it. So this always, as it should, spark or beg the question about, well, I thought we're not supposed to talk to anybody after harm events, or certainly after you're named in litigation. And let me talk about harm events, because that is the least protected when you talk about doing peer support. It depends on the state, but in most states in the US, peer support conversations are technically discoverable. And so we just, really thought through this with our risk insurers and our defense attorneys and patient advocates and lots of different people. Should we do this, or is it going to put the clinician at risk for being harmed by having had this conversation if they end up in a lawsuit? And our resounding answer to our own question was, we have to do this. We have to do peer support. It's the right thing to do. It's what the data shows us that is desired. And we already have data showing what happens to unsupported healthcare providers. So whatever risk it gives us, which I'll address, it pales in comparison to our doing business as usual, which is just letting people be isolated and suffer. So the potential risk, as you litigators obviously know, is that if I'm named then subsequently, excuse me, as a defendant, and the plaintiff's attorney will ask me, did you talk to anybody about this? Of course, they're looking for me to name a colleague who weighed in and said, I don't think you should have used that incision or, chosen that medication or what have you. And then they could subpoena that, person and it would be held against me in a trial. they're not looking for, did you get emotional support from a peer? But okay, so I would guess that the reason I've never seen this actually, getting into litigation after the many years we've had peer support programs, is, probably the defendant doesn't, they're not saying, yes, I talked to a peer supporter. But if they did, and let's say I had done the peer support for Jason, and I got subpoenaed, the way we mitigate the chance of this causing Jason any harm would be, we don't take any notes. So any peer support program, there shouldn't be any notes that anybody takes about it. And it will have happened, of course, several years before the actual litigation. And so, what am I going to say? Like, I don't know exactly the specifics of what we talked about, because there's a good chance I'm not even in his discipline, right? You don't have, I'm not sitting there when I'm listening to peer support, judging what he should have done. Should be done in a protected, event analysis or a morbidity and mortality conference. I'm listening, yes, to the event, but then what they're going through emotionally around that event. And so, we just looked and said, the risk is real, and it's a potential risk, but it's very, very small. And again, it pales in comparison to the risk of not doing this. So, I've worked with healthcare organizations in many states in the US, and the attorneys always ask this question, as they should, and have been satisfied with, like, okay, that does make sense. It's the right thing to do. Let's not let this incredibly dysfunctional legal system, which is dysfunctional for patients and families in terms of getting what they need and deserve, getting their needs met, as it is for, it's really a terrible mismatch, as you all know. That's why there's the collaborative. So yes, it's discoverable, but here's why we say we should do it anyway. So there's, many things we can provide peer support for. This is, just one list of them. I don't know if you noticed, but I do not use the term second victim. And the reason I don't, plain and simple, is because I work closely with patient advocates, including several on the best practices committee, but I've worked with them for years. And they do not like our referring to ourselves as victims when we've harmed them. And for me, that was enough to say a term that I think had good use when it first came out. It needs to be retired. We should not refer to ourselves. We're not victims of anything. We're really not. And this is also, it's not about peer support or about errors, but it's from Parker Palmer, who says, it's also the idea of thinking of yourself as a victim sort of lacks agency. And he sees us having much more agency, as do I. And I think everybody who's participating in this today. And I just want to end with a quote that I got up from Twitter that I just thought was really beautiful. And to me, it wasn't about this, but it really speaks to it. I dream of never being called resilient again in my life. I'm exhausted by strength. I want support. I want softness. I want ease. I want to be amongst kin, not patted on the back for how well I take a hit or for how many. Instead of hearing, you are one of the most resilient people I know, I want to hear, you are so loved. You are so cared for. You are genuinely covered. And I do want to just finally say, everything that we are doing, everything is in service of taking much better care of patients and families. Everything.
Thank you, Dr. Shapiro. Thank you. That was so helpful, and I think really guides how important peer support is. Dr. Lees and Dr. Nightingale, would you be able to share your experiences of starting the colleague support panel at the University of Oklahoma with us?
Sure. I think the point that Dr. Shapiro mentioned about it not just being, a random person or someone that even has the right personality, but we did have an intensive training program. We had, a number of key stakeholders involved. And I think the important thing is just that ongoing support. I think where we've had probably the biggest challenges is one, the automatic referral process. We can identify those, but even though, it's described as a big need, and a lot of, I think, physicians out there that may need this, they don't always ask for help. And I can't tell you an exact number. I would say it's definitely, honestly, in probably the 10% range. I don't know what, Dr. Shapiro, your experience has been in Boston, but, some people, even though they feel they may need it, they don't really want to ask for that help. So.
And I think the other reason this came out really was a lot of what happened with my case and how many people were involved, and I think good does come out of hard situations, and I think there were several other people that got named in that case. I think it goes back to some of that shame and embarrassment, that feeling of you kind of taking other people down, is kind of how I felt. But I think the good thing is that what it did is it pulled us together in looking at how to support each other. And so then in talks that Jason and I had, and with Robert Letton and some of the others, he's pediatric surgeon, but how then do we bridge across service lines? And I think to Joe's point about when we were talking about setting up the peer support, we had those same discussions about discoverability and not writing things down. But I think that crossing service lines is really key, because again, I think it does take away some of that non-judgmental, because I never felt judged by Jason. I mean, I felt like I could go to him for help, and he was very helpful in the care, but he never said, why did you do this? Or why did you do that? Or, and so I think, in that one, that was several of the things we looked at. The other was calling those referrals, but I think it still goes back to breaking down that shame. And I think those reaching out is such a key point, but people do still have to respond. And again, I think it's one of the reasons I've been so open about talking about things, but I think we still have a long way to go. And I think this is the start of it. And so I think this is such a great venue, and it's such a needed topic. And so I'm so thankful that you're willing to have these conversations, because it's really needed in healthcare, because I think if nothing else, the last 3 years have made it just even harder because people's nerves are frayed. And I think this is just such a valuable conversation.
Thank you.
I'd like to make about our group and that lawsuit, and again, I wasn't named in it, but I was very involved. But at least 4 of the people, I look at Dr. Nightingale, who runs the largest federally community health center in Oklahoma now. 2 of the other people are now associate deans in our institution. Another one leads a pediatric surgery group in Jacksonville. I mean, these are really good doctors, in my opinion, and I would send my family to any one of them, but it was just a very unfortunate situation. And you're going to lose people like that have real potential in our field if we cannot support them. And I think, fortunately, we kind of held it all together, but it wasn't easy, and we were able to get the support downstream to really implement some of these programs. So
can I just add something? Is that okay?
Absolutely.
I was thinking about what patients and patient advocates might be thinking when they hear about this, and one of the things that I get asked, actually, when I'm doing training, so I do a ton of training of peer supporters, is, well, what if the person involved in the event is really not taking responsibility? And the first answer to that is, when that person is offered peer support, they're not going to want it, because they don't. I mean, first of all, I have personally never encountered anybody as a colleague who didn't care or just said, this is other people's faults and I'm just, it's not mine, or deny and defend, or whatever those bad things are. I haven't personally encountered them, but they're out there. We know that. So, if somebody, you offer peer support and they don't feel like, they don't want, they're not going to say yes. So we're not really talking about peer supporting people who are behaving badly. Let me say that. For people who are behaving badly, they're denying, they're, whatever they're doing, they're blaming other people. That is the organization's responsibility to deal with them so that they don't go on to cause further harm to patients and families by not telling them the truth, or by doing all those other things that can be incredibly destructive. It's why I also believe you should pair peer support with disclosure and apology, or communication coaching after harm events, so that you can help clinicians actually, kind of manage their emotions so they don't dump them on their neediness or their upset on patients and families, because that's not up to patients and families to deal with. So I guess what I want to say is that we're talking about peer supporting people, most people who care and who are not in denial. But that small other group, which of course they're there. Those people need to be dealt with by the organization and need to be prevented from doing further harm.
Thank you, Dr. Shapiro. Thank you to all of you. I want to be cognizant of the time. And I know we've now reached the top of the hour, so the conclusion of this webinar. A huge thank you to Dr. Nightingale, Dr. Lees, Dr. Shapiro for sharing your experience and your wisdom, for being so vulnerable. We really appreciate it. Thank you also for everyone who has joined us today. In the last hour, we have discussed emotional impact on clinicians after harm events and litigation, explored strategies that litigators can use to support clinicians through the process of litigation, and delved into the importance of peer support. As mentioned at the beginning of this webinar, I want to just make note that today was the first in a 4-part series brought to you by the Collaborative. The February 24th webinar will feature a panel of attorneys with extensive experience in the field of medical malpractice. Then on March 17th, we are very honored to welcome Dr. Jeff Goldenberg and Naomi Kurtner, founders of Talia's Voice, who will provide powerful insight into the impact of malpractice litigation on patients and families who have been harmed by medical error. And then finally, on April 21st, the series will culminate in a webinar in which all stakeholders in the malpractice process join together for conversation. This webinar will be focused on breaking down the silos that often form and discussing ways in which communication and resolution programs can improve the process for all parties that are involved. We hope you will be able to join us for each of these webinars in this mini series. I know that we are out of time, but for questions, I'm sure there's questions that might have arisen. I've heard from the Collaborative that you can email the Collaborative Attorney Alliance email with any questions, and we will be sure to get those answered for you. And I believe that is the CAI@uw.edu. But please, Nicole, let me know if I'm wrong. Thank you for everyone. Yes, I was right. The CAI@uw.edu. That's right. Thank you.
Thank you so much, everyone, and thank you for joining us. And we will see you again next month. Take care, everyone.
Thank you.